Thank you. I'm very grateful and privileged to have this opportunity to talk to you. My topic is options when mitral valve repair alone is not enough in relation to LV size and sphericity. And as long as I can, yeah. I don't really want to spend too much time, but just very important to keep in mind at all times the shape and the dynamic changes that do happen. Now, we know that in ischemic MR, part of the ventricular disease is addressed by concomitant revascularization, and when the LV dilatation is limited below 65 at end diastole, there's a high rate of success with repair. However, poor survival and low rates of LV reverse remodeling in patients with LV and diastolic diameters exceeding 65 urge the need for an adjunctive procedure in this patient group. Such procedures, which are some that can be applied from outside and some from inside. From outside, we have the external ventricular restraint devices which prevent and may interrupt the vicious circle of ongoing remodeling by reducing wall stress. Combined with restrictive mitral annuloplasty, this approach has shown good results in non-ischemic functional MR. Of course, you can understand the technical challenges that will occur when you combine this with bypass grafting. So functional or secondary MR, the valve leaflets are anatomically normal but do not fully coap because of annular dilatation and restricted leaflet motion, secondary to increased ventricular size and sphericity. Such a remodeled ventricle is often associated with lower ejection as heart failure symptoms of NYHA 3-4. And we know that progressive LV remodeling, characterized by progressive LV dilatation and change to a more spherical shape, can result in functional MR. The causes of which can be either annular dilatation, papillary muscle displacement, and/or caudal tethering. Surgery in this situation is controversial as the MR is consequence and not the cause. Prognosis, therefore, is more related to the underlying cardiomyopathic process. It's also that functional MR is a vicious cycle. It leads to an increase in preload, wall tension, and LV workload, all of which in a positive feedback loop cause further dilatation. And the presence of functional MR itself is the independent risk factor for poor outcome, both in non-ischemic and ischemic etiologies, and we know that very well. Dion also said that uncorrected mild MR as well as moderate to severe is associated with ischemic cardiomyopathy, is associated with reduced long-term survival. Now let's just see what are the options that we can do. So Vass and Judinan in 2010 reported 37 ischemic MR patients with low ejection fraction, and all the patients had both papillary muscles encircled with a 4 mm PTFE tube, correcting their lateral and downward displacement. Annuloplasty rings were moderately undersized or normal. Of course, they had bypass grafting. And the efficiency was evaluated on mitral stability, ventricular parameters, and of course, the functional status. They had none to trivial residual MR in 31 patients and mild to moderate in 4. 2 patients died during follow-up. Their follow-up ranged up to 84 months, which showed stability of a successful double-level mitral repair. And follow-up beyond 1 year showed improvement in ventricular diameter, ejection fraction, LV volume, as well as sphericity index. LV reverse remodeling changed from 70 to 55 and ejection fraction from around 30 to 45. They concluded that reapproximating the papillary muscles has an immediate effect on mitral leaflet mobility by suppressing the tethering which results from displacement of the papillary muscle. It has an effect in preventing recurrent MR by avoiding further papillary muscle displacement. So it's immediate effect as well as follow-on effect. And reverse remodeling can be expected. Khalil combined papillary muscle relocation, PPMR, mitral annuloplasty versus only annuloplasty. They had 69 patients with severe ischemic who matched and one-to-one and underwent grafting associated with restrictive annuloplasty. So they used a CV4, CV5 Gore-Tex placed first at the head of each papillary muscle and subsequently through the ipsilateral mitral annulus. So it was just to plaster laterally both of them. They relocated both the papillary muscles to minimize the mitral valve tenting area. Usually one head of the anterior, and then among the three heads of the posterior, both the anterior and posterior were relocated. So try and get a better attachment laterally to the annulus. The description for posterior papillary muscle anterior head was that it was responsible for the Siegel sign and that respective tenting, and so it should be performed in addition to the other head. They did a comprehensive pre and post two-dimensional and three-dimensional echocardiographic examination, 5-year freedom from cardiac-related event in the papillary muscle repositioning plus restrictive annuloplasty in the isolated group was 83 as compared to 65 in the not group. Recurrent MR equal to or greater than moderate occurred in 2 patients in the papillary muscle repositioning as compared to 8 patients in only restrictive annuloplasty group. This also resulted in a significant reversal in left ventricular remodeling compared with isolated restrictive annuloplasty. It also reduced the tenting area and the coaptation depth with respect to restrictive annuloplasty with less incidence of MR. Langa from Joachim Schaffer's unit in Homburg am Saar did this ring plus string. They wanted to address primarily annular dilatation, which is addressed by the ring, but does not correct the severe leaflet tethering, which is attributed to papillary muscle. So they proposed an adjunctive papillary muscle repositioning under TOE guidance in the loaded beating heart using a transventricular suture. So this is their suture, which is going from the head of the papillary muscle and coming out through an aortotomy between the junction. And then it's tightened as the echocardiogram is postoperative reviewed. They identified patients with a tenting height of more than 10 millimeters, which were identified as high risk for repair failure. In all these patients, they combined the restrictive annuloplasty with the adjunctive string, which was, as I said, a Teflon-plated 3O PTFE suture anchored to the posterior papillary muscle via a horizontal aortotomy, which was exteriorized through the aortomitral continuity and tied in the loaded beating heart. They found that tenting height and tenting area decreased. The distance between the posterior papillary muscle and the aortomitral continuity decreased naturally because of the tying. Survival at 2 years was similar, but freedom from MR more than 2 was higher in the ring string group. There was also improvement in the end diastolic and end systolic parameters, decreased in the ring string group but persisted in the control group. During follow-up, only 1 patient of the study group required reoperation, while 2 control groups underwent reoperation. They concluded that their novel approach attenuates high risk of repair failure in patients with severe leaflet tethering and results in remodeling. I'll just go through briefly the RESTORE MV, randomized evaluation of treatment of off-pump repair of the mitral valve. This is using the Coapsis device, which is composed of a dual-headed posterior pad and a single anterior pad. The suture cord is shortened after placement to shape the LV and decrease functional MR. There's a long axis view, which is the positioning of device, and on the right you'll have the relationship of the posterior pads to posterior mitral annulus and the papillary muscle. So the objective was to determine whether patients with functional MR would benefit from ventricular shaping by coapses. This was placed without chiropulmonary bypass to reduce the functional MR. They randomized patients in a multicentral fashion for patients getting the functional MR in CABG only group or CABG with mitral valve repair. Patients were allocated, so I think this is important to remember. So in the patients with the mitral valve repair stratum, patients were subjected to undergo in one-to-one fashion either CABG with ring annuloplasty or CABG plus coapses. In the randomization to CABG alone, it was either CABG alone and CABG plus coapses. So there wasn't a group where they had CABG plus ring annuloplasty plus coapses. So it was the treatment group which consisted only of CABG plus coapses. This is a bit confusing slide, but all I want you to concentrate on that there are two groups, which is the treatment group, which is from each, which has the coapses device, and the control group, which does not have the coapses device. They found that overall survival in the treatment group, which is either randomized to CABG plus mitral annuloplasty or coapses, was better as compared to the control group, as was the complication follow-up recurrence-free interval. Unfortunately, the study was terminated when they failed to secure funding, but they had 165 patients randomized. Control and coapses both produced decrease in LV and diastolic and MR at 2 years, which was significant. Coapses provided a greater decrease in LV and diastolic dimension. Control had lower grades of MR during follow-up, surprising, but coapses showed a survival advantage compared with control. Complication-free survival, including death, stroke, MI, and valve reoperation, was significantly greater with coapses. Analysis of Restore MV indicates that patients with MR, functional MR requiring revascularizing, treated with ventricular reshaping rather than standard surgery, had improved survival and significant decrease in major adverse outcomes. This is the ACORN CAP trial, which is already published their immediate results, but this is the long-term 5-year safety and efficacy of mitral valve surgery with and without the core cap in patients with dilated cardiomyopathy and NYHA 2 to 4. So what they took is from the original ACORN trial, 193 patients who were enrolled in the mitral valve repair stroke replacement strata. Of these, 102 were randomized to mitral valve surgery alone, and 91 were randomized to mitral valve surgery with implantation of core cap, which is the treatment group. Just to refresh your memory, so this is also forming the basis for a fresh FDA application. So initially, their first paper produced a 30-day mortality of only 1.6. At 5 years, the total mortality was 30% with an average annual of 6%. The effects of mitral valve surgery led to a progressive decrease in LV and diastolic and systolic, which were highly significant at all times. So this is irrespective of core cap. At the end of 5 years, there was an average reduction of approximately 28% from baseline. 29 patients had recurrent mitral MR and 5 patients underwent repeat mitral valve surgery. However, when they evaluated the patient who had the core cap, all these were greater. They had greater decrease in left ventricular and diastolic volume, which was significant, and that core cap had an additive effect. They demonstrated that long-term improvement in LV structure and function up to 5 years supports the evidence of combining core cap for device for patients with non-ischemic heart failure with severe LV dysfunction. I just want to now go through a little bit about how we can get to the point where we can avoid so much dilatation that we need to think about an additional procedure. And we have been interested in patients with moderate mitral regurgitation in ischemic group undergoing revascularization, a point that was being discussed. I'm just good that it came up. Now, in patients with moderate mitral regurgitation undergoing CABG, the evidence for intervention is 2AC, consensus of opinion, but not really very good studies. So we evaluated in the Rhine trial mitral valve annuloplasty plus CABG versus CABG alone in moderate functional MR. This was presented at the AHA and fast-tracked into a publication in Circulation, which was in editor's pick, as well as the AHA journal's pick. We had previously reported that functional MR occurs in 40% of patients following MI, which is a result of LV remodeling and dilatation. Mitral valve is tethered and pulled apart, usually mild to moderate, but heart failure and death is increased by up to 3 times. And of course, most have triple vessel disease and benefit from CABG. So we designed this single-blinded randomized controlled trial into 2 groups. Patients were randomized in a 1-to-1 ratio where they were undergoing either only CABG, complete with the pedicle lima, or CABG plus mitral valve repair, complete rigid or semi-rigid mitral annuloplasty. Now, there have been many reports of treating which have been retrospective analysis or studies where there hasn't been a proper randomization, especially the one from Mihalovic from Cleveland, where they evaluated their retrospective study. But the problem we found was there was no standardization of ring assessment. So here we were very keen and we were very strict about it. They must have complete rigid or semi-rigid, and preferably the IMR etiologics, but it was not compulsory. Sized by measurement of anterior leaflet, downsized by 2 if alternative ring was used, and we should aim for a coaptation length of at least 8 millimeters, and the patient should not leave the OR with more than trace MR. So the important principles were complete revas, complete rigid or semi-rigid, no flexible bands, 2 sizes undersizing, and no more than trace MR. All patients who were referred for elective CABG with moderate functional MR as defined, ERO 0.2 to 0.39, regurgitant volume 30 to 59, fraction 30 to 49, and vena contracta width between 0.3 and 0.69. Our primary hypothesis was adding annuloplasty to CABG in patients with moderate MR improves functional capacity, and the secondary hypothesis was it also improves LV reverse remodeling, MR severity, and BNP levels. So at the end of 1 year, our primary endpoint was functional capacity with peak oxygen consumption. Assessment was blinded to treatment allocation, and secondary endpoints, reverse remodeling, MR, and BNP. In the interest of time, I won't go through all the slides, but there are some important slides, which is there was an increase in cross-clamp and bypass time in patients undergoing CABG plus insertion of restrictive annuloplasty. It was significant. However, the important point, which was very good for us, was that 85% of the patients did have the IMR etiologics, 15% had the CE physio ring, and the mean ring size was 28 millimeters. Primary endpoint, functional capacity at 1 year, was significantly better in patients who had undergone CABG plus annuloplasty ring as compared to CABG alone. There was significantly better LV remodeling at 1 year. Obviously, there was less MR. There was better NYHA class, and the BNP was also moderately improved. This study was limited because we stopped early for benefit after review of interim. It was a single endpoints determined at 1 year, and it was not designed nor powered to evaluate clinical events in trial. So I'll end by concluding that compared to CABG alone, the addition of mitral valve annuloplasty to CABG in patients with moderate functional MR improves functional capacity, LV reverse remodeling, mitral regurgitation, and BNP. We have to wait for long-term clinical outcomes. CABG plus annuloplasty required longer operation times, increased intubation, hospital stay, and blood transfusion, but it should be considered in patients with moderate ischemic MR. Thank you.